Good afternoon. Today we are going to discuss about certain cases. The first one is an 8-year-old female child with complaints of redness in the left eye since 2 weeks. The past history revealed a history of primary complex. Manto test was positive. And if you take a look at the lesion is whitish or yellowish with surrounding hyperemia, which is a characteristic feature of your flectanular keratoconjunctivitis. This is one another picture. If you see very carefully, the lesion is white in color where the surrounding hyperemia is very much more prominent. So this is characteristic of flectanular keratoconjunctivitis. Next we come to a 25-year-old female who came with a sudden decrease in vision in the right eye for 1 week. It was associated with painful eye movements and there was difficulty in recognizing red color. The fundus examination revealed disc edema. See the margins, you're not able to see the margins at all. That is disc edema. And there are cotton wool spots and hemorrhages as well. MRI revealed demyelinating plaques in the periventricular region. Next is a case of a 35-year-old female who presented with complaints of drooping of the left eyelid for 2 months, which was especially worse towards the evening or the end of the day. And she had binocular diplopia in left gaze. There was no decrease in visual acuity, and she did complain of having difficulty in breathing intermittently, and there was a history of increased fatigability was there. Ptosis in the left eye, which became gradually, which worsened towards the evening, but there was no drop in visual acuity, and she had increased fatigability as well. So the fourth one is a case of a 55-year-old male with complaints of joint swelling, especially the small joints of both hands, since several years, and he had a history of recurrent redness of both eyes, which is associated with pain initially. So this is a case of a scleromalacia perforans. You can see that the sclera is totally thinned out, and you can see the underlying uvea seen through that. And this patient is likely to go for a perforation. So scleromalacia perforans is the diagnosis in this case. So what is so common about all these things? So the first one, flectin, it is usually a reaction to an endogenous protein. This endogenous protein can be either your staphylococcal antigen, which is where it's commonly associated with blepharitis, or it could be a tuberculous antigen. So since in our country tuberculosis is more common, we commonly come across cases of flectanular keratoconjunctivitis associated with tuberculosis. The second one is a case of optic neuritis, where you were able to see the demyelinating plaques in your MRI. So this is suggestive of multiple sclerosis. Whenever optic neuritis cases, you have to do an MRI, and if you are able to find out an association and you are able to pick out a picture, then it's probably demyelinating plaques on your MRI. It will probably indicate multiple sclerosis, and the disease prognosis will depend on that. The third picture that you saw, the third case series, which is the third case which is discussed, was ptosis. And here the ptosis, which is increasing towards the fag end of the day after work and other things, is suggestive of myasthenia gravis. So, and the fourth one was scleromalacia perforans, which is seen in rheumatoid arthritis. So what is so common about all these things? So these are eye manifestations or signs in the eye, which are actually manifestations of your, yes, you guessed it right, systemic diseases. So today we are going to see about systemic diseases and the eye. So what systemic diseases can you pick up from your eye manifestations, and also what are the eye manifestations which you may expect in systemic diseases, so that you'll have to treat them appropriately. So that is the topic for today's discussion, systemic diseases and the eye. So eye can be, it may be the initial presentation of a systemic disease which you picked up can lead to a better diagnosis for the patient, or it could be a manifestation of a already discovered disease where you need to manage the eye condition appropriately so as to save the patient's vision. So these are the two important things as far as this topic is concerned. So we'll go into systemic diseases and the eye. The first and foremost will be diabetes mellitus and the eye. So what about diabetes mellitus? Diabetes mellitus can involve a host of eye, can cause a host of eye lesions right from the lids, that is from the anterior aspect to the posterior aspect. So from the lids it can cause blepharitis, hordeolum internum, externum can be caused. In conjunctiva is nothing but sludging of blood in the conjunctival vessels. It is just for the continuation sake of it. In cornea, you will have recurrent erosions because of adhesion, there will be defective adhesion between your basement membrane and the epithelium. So your patients with diabetes are more prone for recurrent erosions. Also, since they are also prone for keratitis, especially a fungal keratitis or any type of keratitis, diabetic patients may be predisposed to develop keratitis more easily than others. Coming to the angle of the anterior chamber, primary open angle glaucoma has got a very strong association with your diabetes mellitus, as well as in the end stage, in proliferative diabetic retinopathy, you can get neovascular glaucoma. Coming to the lens, in pupil, some pupils may not dilate very well in patients with diabetic mellitus whom you are taking up for cataract surgery. You can find that pupils may not be dilating that very well. Lens, you can have a snowflake cataract in insulin dependent diabetes mellitus or type 1 diabetes mellitus. You can have a snowflake cataract. In adult cataract, there is an earlier onset and a faster maturation of your adult cataract. So diabetes and eye, here are the pictures. So this is a picture of your snowflake cataract. And this is a fundus picture. Look at the enlarged cupping here. This is a case of glaucomatous optic atrophy, where the enlarged cup and the thinning of the neuroretinal rim and bayoneting can be seen here. This is a case of neovascular glaucoma, where you can see new vessels over this iris. These new vessels will initially bridge the angle, causing an open angle glaucoma, open angle component of neovascular glaucoma. Later, this fibrous tissue will contract and pull the iris towards the cornea, leading to angle closure glaucoma in the late stages. Then coming to the vitreous, you can have asteroid hyalosis, which is nothing but precipitation of calcium soaps in the vitreous. Vitreous hemorrhage can occur as part of your proliferative diabetic retinopathy. As far as your retina is concerned, you can have non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. Optic nerve involvement can occur in the form of an anterior ischemic optic neuropathy or posterior ischemic optic neuropathy or optic neuritis rarely. Coming to the orbit, you can have orbital cellulitis, which is more common in diabetic patients, as well as mucormycosis. This mucormycosis is a devastating fungal infection. All of you would have heard about it, especially in the setting of your coronavirus disease. Mucormycosis is a devastating fungal infection which occur in diabetic patients, especially those in diabetic ketoacidosis. And nowadays you're hearing about it in the set of in the set of coronavirus patients who are diabetic and they are predisposed to and who have a weakened immune system which predisposes them to mucormycosis. It's a very, very fatal, devastating fungal infection, a very serious one, which with a very high mortality as well. Coming to the extraocular movements, multiple cranial nerves can occur as part of your diabetic microangiopathy, and they will usually recover with time. So refractive error, hyperglycemia will cause a myopic shift and hypoglycemia will have a hypermetropic shift. So these are about the diabetic manifestations in the eye. So in hyperglycemia, there is actually water accumulation in the cortex. So the difference in the refractive index between the nucleus and the cortex is altered, which induces a index myopia in the patient. So, so if they are hyperglycemic or if the diabetes is uncontrolled, the patient will have a tendency to go towards a myopic refractive error. Whereas if they have a very strict control, you may have an increase in their hypermetropic status. So this is a picture of mucormycosis. You can see the black S chart, and it's a devastating fungal infection. Diabetic patients, especially those with diabetic ketoacidosis, especially in the post-COVID setting. So we move on to the next systemic disease. So having completed diabetes mellitus, we are moving on to tuberculosis. Tuberculosis and eye. In eye, it is usually it's a manifestations of your extrapulmonary tuberculosis. Usually, it is not associated with pulmonary tuberculosis. It may be the only presentation of an extrapulmonary tuberculosis. And the most common presentation will be a posterior uveitis, involvement of the posterior part of the uvea. In conjunctiva, you can have a flectanular keratoconjunctivitis. If it is an anterior uveitis, it is a granulomatous uveitis. Tuberculosis being a granulomatous disease, you have a granulomatous uveitis. In uveitis, you have two types, non-granulomatous and granulomatous uveitis, and in anterior uveitis, you have a granulomatous type of uveitis in tuberculosis. So tuberculosis has a tendency to affect the posterior segment more. So if it's a posterior uveitis, it can present as a solitary tubercle. It can present with multiple tubercles, or it could be presentation or there could be a presentation with tuberculoma. So posterior uveitis, you can have a solitary tubercle-like presentation, or you can have multiple tubercles, or it could be a tuberculoma-like presentation. Because the choroid being very vascular, the uveal tissue is more involved in systemic diseases. So you can have a choroiditis. This choroiditis will have a typical serpiginous nature, and it can be multifocal or it can be a solitary lesion. So multifocal lesions can be present, or you can have discrete lesions. So initially it will be non-contiguous. Non-contiguous areas will be involved, which later coalesce together to form a diffuse inflammation, which will have an active proliferating edge. So you can see the choroiditis. This is an active choroiditis. If you see, the borders are all hazy and it's yellowish, and this is a inactive lesion, uh, partly subsiding kind of thing. So you can have multiple choroidal tubercles. In addition to that, you can also have immune recovery uveitis, especially patients with HIV who have coexistent tuberculosis infection when they are on heart therapy. They have a tendency to react with producing an uveitis, which is called as immune recovery uveitis. When they are on treatment, they have a tendency to have a uveitis, which is called as immune recovery uveitis, because of the immune response against your antigens. And as far as retina is concerned, you can have an exudative retinal hemorrhagic periphlebitis, inflammation of your veins as well. So coming to the orbit, you can have a draining sinus tract or dacryoadenitis. Inflammation of your lacrimal gland can be there. So that was about tuberculosis. So remember, flectanular keratoconjunctivitis, granulomatous uveitis, posterior uveitis, choroiditis. These are some of the commonest features of your tuberculosis. Moving on to leprosy. So eye involvement is seen more commonly in lepromatous leprosy. In the lids, you can have madarosis, that is loss of eyelashes, and your eyebrows also you can loss of hair, which is called as madarosis. You can have nodules on your lids. You can have an entropion or an ectropion depending on where the scarring is occurring. The most common presentation, however, will be a low-grade chronic iridocyclitis. So iridocyclitis is nothing but inflammation of the iris and the ciliary body. So the leprosy has a tendency to to have a presentation similar to in a low grade as a low grade chronic iridocyclitis. If you wash the anterior chamber over the iris, you can see iris pearls, which are pathognomonic of your leprosy. So this is the picture. You can see the iris pearls, and there is synechia because of the uveitis in this patient. So coming to the iris atrophy can occur. The pupils will tend to be myotic because of a synechia formation and other things. In cornea, you can have an interstitial keratitis, or you can have corneal leproma. You can have scleritis, episcleritis. It also can induce cataract formation, and intraocular hypotony can occur because of involvement of your ciliary body. So these are some of the common features of leprosy. In cornea, you can have interstitial keratitis, corneal leproma. You can have a granulomatous chronic iridocyclitis, iris atrophy, scleritis, episcleritis, cataracts, and intraocular hypotony. In tubercular leprosy, you have keratitis, which can be neuroparalytic because of involvement of the seventh cranial nerve. Tubercular leprosy has a tendency to involve your peripheral nerves. So neuroparalytic because of involvement of the seventh cranial nerve, and neurotropic because of involvement of your fifth cranial nerve. So fifth cranial nerve is involved with sensation. In neuroparalytic keratitis, what happens is there is involvement of your seventh cranial nerve, which causes paralysis of your orbicularis oculi. So there is an inability to close the eye properly, leading to lag of thalamus and exposure keratitis. Fifth cranial nerve is involved with the sensation, and if the corneal sensation is impaired, you're going to get a neurotropic keratitis. So this is exposure keratitis. This is a fluorescent staining of the corneal erosions. So it's better visualized with a cobalt blue filter. So when you do a fluorescent staining, if the epithelium is not intact, the cornea will take up the stain, and that is fluorescent staining of your cornea, which picks up the exposure keratitis in a patient with lag of thalamus, and here is, I think, some amount of ectropion as well. So leprosy, because of lacrimal gland involvement as well as conjunctival keratinization, will lead to keratoconjunctivitis sicca or dry eye syndrome. In addition to that, leprosy can also cause peripheral choroiditis, vasculitis, and papillitis, and it can also cause acute or chronic dacryocystitis. So these are the main pathognomonic features. Leptomatous leprosy, you have one set of involvement, whereas in tubercular leprosy, it's more of your nerve involvement, which leads to exposure keratitis and other things. So it's a chronic iridocyclitis with periphlebitis, choroiditis, vasculitis, dry eye syndrome, acute and chronic dacryocystitis. So these are some of the commonest features of your leprosy. We move on to the next systemic disease. It is syphilis. We have different eye manifestations in congenital syphilis and acquired syphilis. So in congenital syphilis, interstitial keratitis is a common presentation. In addition to that, you can have anterior uveitis as well as a pigmentary retinopathy. In acquired syphilis, you have madarosis, loss of eyelashes in the eyebrows as well as your lids. Keratitis can occur. Anterior uveitis, something similar to that. Chorioretinitis, neuroretinitis. So what is neuroretinitis? When there is an inflammation involving your optic nerve head with involvement of your macular region, we call that neuroretinitis. When you have hard exudates in the macular region, we call that neuroretinitis. where there's not only disc edema, but there's also some other involvement of the macular area that's called as neuroretinitis. Neuroretinitis does not occur in multiple sclerosis because your myelination will stop short at the disc level. So there is no neuroretinitis, does not occur in multiple sclerosis. So if you have a neuroretinitis like picture, multiple sclerosis is automatically ruled out. You can have your Argyll-Robertson pupil, and any cranial nerve palsies can occur in acute syphilis. So this is a picture of congenital syphilis showing you interstitial keratitis. You can see the cornea is very hazy due to interstitial keratitis. In neuroretinitis, as I told you, the disc is inflamed, the margins are all blurred, disc is edematous, it is hyperemic, but at the same time you're able to see hard exudates radiating everywhere from the macular region. This is typical of your neuroretinitis. So in multiple sclerosis, you will not have any macular involvement. So moving on to the next disease. So syphilis, you should remember the manifestations are different in congenital syphilis as well as compared to your acquired causes for syphilis. Moving on to HIV. So HIV is human immunodeficiency virus infection. So in the lids you can have what is called as a different kind of sarcoma, which is called as a Kaposi sarcoma, which occurs in patients who are infected with HIV. So that is Kaposi sarcoma. In addition to that, they can have a multiple molluscum contagiosum, and also herpes zoster ophthalmicus is common in HIV patients, especially if you come across a young patient with the herpes zoster ophthalmicus. So herpes zoster ophthalmicus is typically an infection of your older age group where you'll have an unilateral involvement commonly, and it will occur in the older age group, 60 years or more than that. If you are finding a 35-year-old or a 40-year-old with HIV, with the herpes zoster ophthalmicus, you have to rule out uh, human immunodeficiency virus. So coming to the orbit, typically in the younger age groups, 25, 30 years, all those age group. So coming to the orbit, so you can have cellulitis, orbital cellulitis can occur. B-cell lymphomas are more common in HIV patients. Keratitis due to uncommon organisms like Microsporidium can occur. HSV, herpes zoster virus or herpes simplex virus keratitis can occur. Anterior uveitis is also more common in HIV patients. So this is a picture of HIV retinopathy. You can see the multiple cottonelle spots and also some hemorrhages which can occur in patients with HIV. This is typical of your HIV retinopathy. So retinopathy, you can have cottonelle spots and hemorrhages. You have a special type of retinitis which occur in HIV patients, especially those who are more immunocompromised. That is called as cytomegalovirus retinitis. You have a brush fire appearance. It's called as a typical brush fire appearance. I'll show you a picture about it. Then if they have a varicella zoster virus infection, they are more prone to develop a progressive outer retinal necrosis, which is another devastating infection occurring in patients with HIV. In choroiditis can be due to rare organisms like your Pneumocystis or Cryptococcus. So remember, HIV retinopathy is a Kaposi sarcoma, B-cell lymphoma, and cytomegalovirus retinitis, progressive outer retinal necrosis, choroiditis, pneumocystis, as well as your Cryptococcus. Choroiditis can occur more commonly in HIV patient. Choroiditis, especially due to pneumocystis as well as Cryptococcus, can occur more commonly in HIV patients. So this is a picture of your CMV retinitis. I told you brush fire appearance, less like the fire is spreading. So lots of hemorrhages and cottonelle spots, and it is just spreading with disc edema. So this is progressive outer retinal necrosis. So the necrosed retina is appearing pale. So we move on to myasthenia gravis. We have taken a look, we have had a discussion about diabetes mellitus, tuberculosis, leprosy, syphilis, HIV, and now we're moving on to a neuromuscular disorder like myasthenia gravis. The muscular disorder, myasthenia gravis. We're moving on to myasthenia gravis. Myasthenia gravis can present with ptosis or diplopia, and these patients have an inability to maintain an up gaze. You try to ask them to look up and try to maintain it, they will not be able to maintain it. The drooping will tend to increase when they try to maintain their up gaze. And you have Cogan lid twitch, which is nothing but a fast excursion of the lid when you ask the patient to see from down gaze to the straightforward position. There is a fast twitch which causing the lid to overshoot. You can also have weakness of orbicularis oculi. We move on to myasthenia gravis. Myasthenia gravis usually manifests with ptosis. We move on to myasthenia gravis. Myasthenia gravis usually manifests with ptosis or diplopia. There is an inability to maintain up gaze. Ask the patient to maintain the eyes in up gaze for 1 to 3 minutes. There will be an increase in the drooping of the lids. This is one sign which we can pick up in myasthenia gravis. Another sign is your Cogan lid twitch. Ask the patient to look down for 10 to 15 seconds and then return the eyes to the primary position. That is, ask them to look straight. The lid will give a brief twitch will be seen when the lid comes back to the primary position. This is called as a Cogan slit twitch. This can be increased by asking the patient to look, sustain for 15 seconds in the downward direction, then again look in the upward direction, and then come to the primary position where you look straight. The stitch will be even more accentuated in that conditions. So that's called as a Cogan lid twitch. 10 to 15 seconds in the downward position, and then when you ask the patient to look straight, when you return to the primary position, then there is a brief twitch of the upper eyelid, which is called as a Cogan's lid twitch. In addition, you can make out weakness of the orbicularis oculi will be there in patients with myasthenia gravis. We ask them to ask them to keep their eyes very tightly shut. After some time, you can see some amount of sclera can be seen showing underneath. That also is a useful sign and to pick out your myasthenia gravis. So this is before treatment. You can see the ptosis, which has a tendency to droop more with time because of fatigability. After treatment, you can do the ice pack test or tensilon test, which can after treatment you can see that there's an improvement in your ptosis. So we move on to multiple sclerosis. Multiple sclerosis, you can have a myriad of presentations, like it can be an optic neuritis. As I told you, it could be a retrobulbar neuritis. Retrobulbar neuritis is nothing but an optic neuritis where you will not have any fundus changes. Fundus changes won't be there. When you look at the fundus, there will not be any disc edema or anything. That's called as a retrobulbar neuritis. Basically, the optic nerve head behind the globe is involved. So the only sign by which you can pick it up is a relative apparent pupillary defect and difficulty in identifying red. All these things should give you a clue of sudden decrease in vision, painful eye movements. All those things should give you a clue about a retrobulbar neuritis if your fundus is going to be normal, or it could be a papillitis where the fundus will show disc edema changes. Or you could have the presentation as an internuclear ophthalmoplegia. Nystagmus can be present, or oculomotor nerve palsies can be seen. So all these things can occur in multiple sclerosis. Most common presentation being your retrobulbar neuritis. So this is a picture of your optic neuritis where there's an inflammation of the optic nerve head with cottonwool spots and hemorrhages. Hemorrhages usually very rare in optic neuritis. So this is a picture. In addition to your optic neuritis, there can be an intermediate uveitis also in multiple sclerosis where the patient will have a sudden decrease in vision with floaters. So that can also occur in your multiple sclerosis. So intermediate uveitis, retinal periphlebitis can also occur in multiple sclerosis. If you do an MRI of this patient, which is mandatory, especially after your first episode, you can pick if there are any demyelinating plaques in the periventricular and corpus callosum region, then it is suggestive of your multiple sclerosis. Next, we move on to rheumatoid arthritis. Rheumatoid arthritis, the typical picture will be your keratoconjunctivitis sicca, dry eye syndrome, which is very common in patients with rheumatoid arthritis. And the other manifestations being scleritis, episcleritis, peripheral ulcerative keratitis can occur, or acquired superior oblique tendon sheath syndrome can occur in rheumatoid arthritis. So you have dry eye syndrome, scleritis, episcleritis, peripheral ulcerative keratitis, and acquired superior oblique tendon sheath syndrome. And as the disease progresses, recurrent attacks of scleritis will give rise to what is called as a scleromalacia perforans, where even without any inflammation, there will be painful melting away of that is, there will be painless melting away of the sclera. So that's called as scleromalacia perforans. So you can see the hands, deformed hands due to involvement of the small joints of the hands. So look at the swollen joints, and this is scleritis. So next we move on to neurofibromatosis. What are the manifestations in neurofibromatosis? In eyelid, you can have a neurofibroma, and that produces a typical S-shaped deformity of the lid. In iris, you can have mammillations, you can have leash nodules, which are hypopigmented, fleshy nodules seen in the iris. You can have optic nerve glioma. Glaucoma can occur in patients with neurofibromatosis. Because of the absence of the greater wing of sphenoid in patients with neurofibromatosis 1, you can have a splenoorbital encephalocele. So this is a patient with neurofibromatosis. I'm sorry about that. We move on to neurofibromatosis 2. Neurofibromatosis 2 is less common. They have an earlier onset of cataract. Ophthalmoplegia can occur, and also hematomas of the retina can occur in patients with neurofibromatosis 2. So coming to other important systemic diseases like Marfan syndrome. So Marfan syndrome is characterized by, if you see, the arm span will actually be more than your height. So they'll have very long fingers will be there, right? Long legs, long arms, long hands and fingers, all those things will be there. So in Marfan syndrome, you will usually have a subluxation of the lens. So it's called as ectopia lentis, where there will be subluxation of the lens. See, there are no absence of sonnules here. So in addition to that, you have a enormous amount of systemic diseases which can manifest with eye signs. But of course, it is too voluminous for me to cover. I've just tried to give you some important diseases and try to give you a perspective in this regard. And I'm sure you'll be able to read much more and gather more information about systemic diseases and eye, which is a rather interesting topic, and learn about the different eye manifestations as well as how to treat them in patients with systemic diseases.